Now Amplify LTC is coming as a live in-person conference. We'll have top industry speakers leading one-of-a-kind classes, many of whom you've heard on this podcast already. You can check out the website at AmplifyLTC.com. And we are so excited at the chance to interact with you in person in Nashville this May. Welcome, everybody, to the Amplify Long-Term Care Podcast. This is Frances Nahas. I'm your host today. I am thrilled to be here with Ronna Hauser, who's the Senior VP of Policy and Pharmacy Affairs for NCPA. Great to have you here.
Thank you, Frances. Thanks for having me.
Awesome. Yeah, absolutely. Can you give our listeners a quick introduction? How'd you land at NCPA? What do you do for them today?
Yeah, absolutely. I've been at NCPA over 10 years. My primary role at the organization is to represent independently owned pharmacies in front of the federal agencies. So I work very closely with those agencies that have a lot of sway over our members and the patients they serve. So CMS, FDA, DEA, it's definitely an alphabet soup, yeah. But Defense Health, TRICARE program, you name it. It's my responsibility to make sure the organization has strong ties with those agencies and the agencies understand, what our members are going through and how they're trying their best to take care of their patients. And we want to make sure that policies and regulations that those agencies are implementing are as friendly as possible to independent pharmacies so we can keep doing our jobs. Awesome. So that's my primary role and really just day in and day out advocating on behalf of our members and trying to bring positive change to the industry.
That's fantastic. How'd you land in the world of pharmacy?
It's a great question. Like many pharmacists I've met along the way, had a desire early on to do something in the medical field and got really close to applying to medical school. But when it came time to make that decision and take that MCAT and submit those applications, I thought, well, I really like chemistry. I really like science. Not sure that I'm all in on being a physician. So definitely knew that pharmacy would be a great career path and where I could use my skills and what I'd learned. So applied to pharmacy school and was fortunate to be accepted. And, all these years later, I think it's a wonderful profession and I made the best decision for sure.
Yep. Did you practice at all for a while before you ended up where you are today?
I did. I practiced for several years in the community setting. So I practiced in the independent setting.
Yep.
I practiced for a chain and I practiced for a grocer. So I did get some good practice experience. And then for several years while I was working at NCPA, I would moonlight. But, after kids and as they get older and whatnot, that became harder and harder to moonlight. But I definitely try to keep in touch with our members and visit local pharmacies here by where I live as often as I can to, understand what's still happening behind the counter.
Yeah. I hear that a lot. It's really interesting too, where it's folks who've actually done the work in the chains and in the community pharmacy. And it's great to have someone in your position who has the perspective of both and what's different, what's better, what's more challenging.
Yeah, I've been very fortunate. The independent I was able to spend time with. Also had a long-term care pharmacy as well. So got to learn the long-term care side of the business as well through that and compounding.
Yeah.
So I feel like many of the issues I work on today, I've at least been able to practice in those environments at one point in my career, which has helped a lot.
Yeah. So let's start there. That's a great lead-in. What are some of the differences or challenges you see with long-term care pharmacies versus your traditional community retail pharmacy?
Sure, absolutely. Well, I see long-term care as a definite positive for our members, an area where they can expand and grow their business with an aging population. So at NCPA, we've had a long-term care division for many years. We encourage our members that are in the long-term care space to get engaged in our efforts. And we also teach our members that may not even know they're providing long-term care services that, yes, actually you are. And you should be able to take advantage of the differences between community and long-term care pharmacy. So a big part of our role is to educate folks who may not even know that they could qualify as a long-term care pharmacy to get into the business and grow, grow the number of beds, grow the number of facilities that they're taking care of. So I'd say there's just as many challenges in long-term care as there are in community, but there's also some pros, in long-term care. For many years at NCPA, we've been fighting against DIR fees. And fortunately, in the majority of the long-term care space, specifically the skilled facilities, there have been no DIR fees attached to those claims. So that has been fortunate because DIR fees have really done a number on our members. And we've been working diligently to get some common sense reforms across the finish line. But needless to say, there's always going to be challenges in any type of pharmacy setting. But long-term care is definitely an area that we feel very positive about, and we encourage our members to get more engaged in.
Awesome. So tell us a little bit about some of the big things you're working on with that alphabet soup of agencies nowadays.
Absolutely. I'm happy to. And I'd say just globally, NCPA represents both community and long-term care pharmacies. So many of the issues, faced by our members are really the same in community and long-term care. And unfortunately, that's payment pressure, downward payment pressure, reimbursement concerns. So again, working for years to try to get common sense payment reforms across the finish line, and really change the way that pharmacy benefit managers pay for pharmacy services. So we have some very exciting movement in Washington, D.C. right now. Definitely, if we can get these reforms across the finish lines, it'll have very positive impact on both community and long-term care pharmacies. And, top line, there's two major reforms, and we're talking about, the next 4 weeks here. Something is going to happen. Yeah. The government has deadlines that they have to meet. So we're coming up on some of those, and they need to move, and make some decisions to keep our government functioning.
Right.
So we're hoping that some of these common sense reforms can be included in that movement. So Medicaid managed care reform and Medicare Part D payment reform is really the top two areas of focus for us right now for the next few weeks. We have to get these common sense policies across the finish line. It would change how PBMs pay pharmacies in Medicare Part D. It would make sure those payments are reasonable and relevant. And then it would change how PBMs pay pharmacies in the Medicaid managed care space. And it would require a cost plus model. So it would require members to be paid, on a NADAC or what they bought the drug for, the national average drug acquisition cost, plus a commensurate professional dispensing fee. So these are very important reforms, and we're working as hard as we can to make sure that these get across the finish line. I think I always tell people the only thing that's going to hold us back is politics, right?
Yep.
So we're staying very positive, we're staying very focused, and I hope to have some really good news here in the upcoming weeks.
So if I'm in the long-term care space today, what could I expect the outcome of something like that to be? So if it were to get passed, what would that look like for me?
Yeah, absolutely. That's a great question. So I know every long-term care pharmacy is different, right? The patient populations and the facilities and, the different mix of facilities and patients you provide care to. I know that some long-term care pharmacies, do provide quite a bit of managed care or Medicaid care. So in those instances, for those Medicaid managed care prescriptions, instead of getting paid very low or below cost sometimes, you would be paid acquisition plus your state's Medicaid cost to dispense. So, across the board, that's usually anywhere from $9 to $13+ depending on what state you're in and how your state calculates those dispensing fees. So that would be very positive if our long-term care members do have Medicaid managed care line of business. But the bigger picture, because we know that long-term care pharmacies and also community pharmacies, a huge portion of their business is Medicare Part D.
Yep.
So the other reform I mentioned, which is reasonable and relevant payment terms, it would, for once and all, hopefully we could, get some clarity here, require CMS to define reasonable and relevant contract terms, including payment terms. Because we know now that CMS unfortunately uses the non-interference clause a lot, and puts up the stop sign and says they can't interfere in negotiations or disputes related to pharmacy payments. So this would actually force the agency to define what reasonable and relevant contract terms are, as I said, including payment terms. So we're hoping to get to a better day in Medicare Part D where we're actually paid for the services we provide. And today, unfortunately, our members are paid below cost, and then either a zero or a very nominal dispensing fee, which, does not allow them to stay in business and serve their patients.
Yeah, so I always think about it for a lot of pharmacies sort of across a formulary. And so you kind of balance, hey, there's probably a bucket of prescriptions you lose money on. There's a bucket that sort of sit in the middle and a bucket you make money on. And you're always trying to kind of balance that to make sure in the end, you come out whole and you've got a business that's sustainable over time so you can continue to care for your community. Is the mindset here like, hey, that tail where you lose money, let's just bring that up so that there's not a scenario where you're dispensing something or doing an activity where you're losing money and trying to make that up someplace else.
Right. I understand what you're saying. And that's always in my mind, that's the over-under argument, right? You go into a federal agency, you're like, we're getting underpaid on X percentage of prescriptions. Well, how many are you getting overpaid on?
Right,
what's the delta there? We don't want to keep having that debate because unfortunately, like you said, the tail, the ones we're losing money on are growing, right? Year over year, we're losing money on more and more prescriptions. So, we can't keep playing that over-under game. So it's really why NCPA is trying to change the pharmacy payment model and move more towards that cost plus model where we're paid what it costs us to acquire the drug, and then we're paid a commensurate professional dispensing fee. I think it's really important when you're talking about commensurate professional dispensing fees to realize, a community dispensing fee is going to be different than a long-term care dispensing fee, is going to be different than a specialty dispensing fee. So we've worked over the years to do several studies that look at those differences in cost to dispense, and moving forward, updating those studies and getting new data out in the marketplace will be more important than ever.
Can you talk a little bit about what that looks like? So if I look at, let's take the three models you just talked about, sort of community, long-term care, specialty. How do they vary? Like what drives the difference in the cost to dispense and how big is that?
Yeah, that's a great question. Off the top of my head, I can't tell you the averages because I don't want to get them wrong. But, we have over time done a separate long-term care cost to dispense study. We know that those costs are, much higher for those settings. It's because of the delivery. It's because of the 24/7 on call. It's because of the attention that you're giving to that facility. The staff to be on call for that period of time, the delivery costs, the packaging, everything adds up. So we know that long-term care cost to dispense is greater than community cost to dispense. And then we know that there's different aspects that go into specialty pharmacy cost to dispense. So again, NCPA has been involved in studies looking at all three. And, it's very important that those get updated, right? And it's a huge lift to update those studies, but it's going to be well worth it moving into the future as hopefully more payers recognize the value and the cost savings associated with a cost plus model of paying pharmacies. I think people are really tired of these hidden fees and hidden costs and not knowing what they're ultimately paying for, from an employer perspective. I think, employers are getting fed up and they're questioning their PBMs, and we're seeing some movement in the industry, which is really nice when we see that a major employer, a major plan sponsor has fired their PBM and tried to go a different route or go with a PBM that's more transparent and has more of a pass-through model. So we're excited to see some of the changes. It takes disruption in our industry to get to the ultimate goal. And, we're happy over the last year or two to see a lot of positive changes in the market. That's great. Yeah. Let's talk politics a little bit, which is probably something our listeners don't spend a lot of time thinking about. So we're funding our government through kind of continuing resolutions at the moment. What's that look like? What's the activity kind of on the Hill? How are you guys working with folks and what does it take in this type of environment to get something like this passed? Sure. Well, everyone wants to punt, kick the can down the road. We're used to this in Washington, D.C. land. So, for better or worse, that's the dynamic we're in right now. But something's going to have to get done. We thought this would have been over with already. I think a lot of people did, including members of Congress, heading into we're in election year here already. Yep. And, this campaigning is about to turn into really nonstop, for better or worse, for all of us. So, there's some work that needs to get done in Washington, D.C. So we're looking at an early March deadline right now, hoping that Congress can stick to that. And, along with funding the government comes other priorities and other things that need to get done. So, we're looking at being a solution there. And some of these common sense PBM reforms, hopefully they have a lot of support and they have a lot of backing. So we're really hoping at the end of the day that they'll pass and make it to the president's desk. But, people are tired of the debate over prescription drugs and the costs associated with them. And, fortunately, there's been a lot of scrutiny on the pharmacy benefit manager role and what role they do play. And are they really saving money like they say they always do. We say, no, they're not. They're actually leading to higher drug costs and inflated drug cost. Let's get down to the true cost of the drug. Let's ban these spread pricing practices that only serve to enrich the PBMs. Let's pay the PBMs an administrative, fee, and then let's pay the pharmacies acquisition plus cost to dispense. So these ideas, these notions that you need to reform the way PBMs work have a lot of support behind them right now from a lot of people in Congress that really matter and are at the decision-making tables. Yes. Every member of Congress matters, but at the end of the day, we know there's certain senators and members of the House that hold sway because of their roles on certain committees and in their leadership positions. So it's making sure that those people at the end of the day that are going to be the few people in the negotiating room know that independent community pharmacy is important and know that helping us help our patients is one of the most important things when it comes to PBM reform.
Nice. How do you think about, can you walk through what that spread pricing looks like and how it really differs from what's being proposed today?
Sure, absolutely. So for a few years, there's been a lot of investigations at the state level that have shown, especially in the Medicaid managed care space, that the ultimate payer, the state, the taxpayer, is getting charged, a much inflated cost than what's being actually paid to the pharmacy to dispense the drug. So where is that delta? Where is that amount in the middle going? It's really going to the PBM and to enrich the PBM's bottom line. And there's been multiple studies, multiple lawsuits, over the years about this at the state level. So, for once and all, we're like, take care of this federally. Some states have made great strides. Some states have reformed their Medicaid managed care programs, but not all. So we're like, we need a uniform application across all states. We need to ban the spread pricing practice. We need to pay PBMs an administrative fee, and we need to make sure that it's a fair and transparent and equitable payment structure for pharmacy. So along with that, and along with the federal legislation that we hope will pass in the next few weeks, I think one of the big changes will be that Medicaid managed care would pay just like fee-for-service does. And then pharmacies would be mandated to reply to the NADAC survey. So for the last several years, there has been a survey circulated by Myers and Stauffer on behalf of the government, on behalf of the Medicaid part of CMS that is voluntary. Today, most all independents that get that survey respond to it. Most all chains do not. So we've been working diligently with our partners at the chain drugstores and the grocers, to ensure that they will, raise their hand and say, yes, when we get it, we'll report to it now. So they have, decided to do that. We all came to an agreement last year. We've been working all of us together, again, specialty, grocer, chain, community. We've been working all together to make sure that we can get that reform across the finish line and change how our members are paid for Medicaid managed care prescriptions. And like I said, it will mandate reporting to the NADAC, but that's one of the few changes as far as something that's affirmative that the pharmacy has to do. Right. The best news is pharmacies will get paid way more fairly and more transparently.
What can pharmacies be doing to help?
That's a great question. So NCPA has a very active legislative action center. So when it's time to take action, we ping our members, and we're very, happy to respond that over the last several weeks, we've had thousands, I think we're almost close to 10,000, messages that have gone into Congress. So that's great. We will be putting that call out again, I'm sure, in the upcoming weeks. So stay tuned. All the pharmacy owners out there, stay tuned. Make sure you're engaged with NCPA and that you're signed up for our Legislative Action Center, because, we will need you again when we get really close to this becoming, hopefully a reality. And like I said, there's, going to be a few people in the negotiating room. We at NCPA are working very hard to make sure we talk to all of those players and that they understand the importance of these reforms.
What's being done at a state level, or what can we do? I always think politically, and you mentioned this, that sometimes things sort of happen here and there across states first, and it takes kind of a bolus of states to bubble those issues up to a federal level. So what are we doing at state levels? What can we be doing? Thoughts on that?
Yeah, that's a great question. We are very active at the state level, and we cannot thank our state partners enough for all the strides that have been made over the last several years. I mean, you look at just over the last 5 years, some of the great work that's been done, some really good reforms have been passed. And then what's the next step? Enforcement. So it's not just good enough to get a law on the books. You have to work on enforcement. So that's been a big priority of ours. I will say that the Supreme Court decision a few years ago, the Rutledge decision out of Arkansas, was a big win for pharmacy. You know, it gave states what they need to be able to regulate PBM activity in the commercial space. You know, we know that we work really hard at NCPA to reform Medicare and Medicaid, but we know there's a lot of prescriptions out there that are being filled under a commercial benefit. So reform in the commercial space is just as important. And we feel very strongly that reform in the commercial space should happen at the state level. So been very active in a lot of fronts. You know, unfortunately, when a good law passes, what happens? The PBMs sue, right? So, you know, we're involved in several legal cases right now where even after the Supreme Court, you know, states, yes, you can do this, the PBMs are never going to stop fighting with their wallets and their pocketbooks. So we have to stay diligent, you know, on the legislative, the regulatory, and also the legal front. So there's several, you know, cases playing out at the state level right now when PBMs have challenged a state law. There's several state laws that are moving forward and have had good positive outcomes for our members. So it's really just trying to replicate the good things and making sure we can keep those good things moving forward and, you know, trying to block any legal activity by the PBMs, trying to make sure that they don't get anything, trying to make sure the PBMs don't get any wins, right? At the state level. A lot of defense goes on, right? It's offense and defense is important. But, you know, I would say that something that we're hoping to replicate is what West Virginia was the first state to do this. But West Virginia now requires a NADAC plus a commensurate professional dispensing fee for commercial claims. So we're watching that very closely. That's only been in effect about 2 years. We're watching that very closely. We're working on some research so that we can share publicly that shows all the savings associated with that. So again, really trying to replicate this model of paying pharmacies, you know, based on acquisition and that necessary dispensing fee, really trying to replicate that across the country. So there's been some really positive strides made in the states, and don't want to name them all because I'll forget someone. And some of our state partners.
Meanwhile, I was going to ask that. I was like, which other states? Give me some examples.
Mine's better than that one. Yeah. You know, I don't want to start naming them because there's so many good things that have happened out there. I only mention West Virginia because it's unique. We know that several states are trying to replicate what they've done. We know that Tennessee has a program that is a little bit narrower than West Virginia's, but still is very positive. So we just, I don't want to start naming because I'll forget someone, but I did want to point that out because those are unique in that they would pay this NADAC plus in commercial.
Yep. Yeah.
So, you know, we're trying to really, again, change the pharmacy payment model, make sure our members can survive, and again, that they're being paid fairly and equitably for all the care they're providing in their neighborhoods.
Yeah. What gets you excited about the future for pharmacy, and particularly for community and independent long-term care pharmacies?
Yeah, absolutely. So I think what gets me excited, I love independent pharmacy. I love all community pharmacy. I think pharmacists are out there on the front lines doing a great job every day. I love independent specifically. I love the entrepreneurial spirit. You know, I love that they can really expand offerings, you know, in a more nimble fashion, you know, based on the communities they're in. You know, I think what we'll see and what kind of excites me is maybe kind of more of a right sizing, you know, where you have maybe a few larger players, fewer than we have now. And then, you know, hopefully if we're able to get some of these reforms in place, I think patient choice too is really important. I think when given the choice, patients will come to our members, you know, much prefer them. And consumer reports have shown that for years. Unfortunately, though, the PBMs steer patients. So haven't even got into that debate yet, but we can talk about some of the work we've done to avoid, you know, patient steering. But if given the choice, I think with payment reform, and then with patients being given the choice to, you know, be a patron at the pharmacy of their choice, I do see, you know, positive future for independent pharmacy. And but it's got to be the entrepreneurial spirit can't die. You know, it has to stay alive. Our members have to expand their service offerings. You know, CPESN is an area that NCPA has put a lot of support into making sure that our members are paid for their clinical services by the medical side of the benefit, try to step away from the pharmacy side of the benefit. Long-term care, as we mentioned, one of those niche services that's growing in importance, compounding. There's a lot of different areas that our members can expand and grow their businesses in, and I think that's what's exciting.
Yeah, it's neat. It's really interesting when we look at kind of the overall market, because 20 or 30 years ago, it was a lot of sort of individual mom and pop stores and a handful of regional chains that looked very traditionally like retail chains. Today, when we look at our base and we look at our customers, they're just very different. It's that nimbleness of kind of being able to be creative about how you serve your patients. And so some of them are those rural, traditional kind of mom and pop type shops, and we see more sort of digital pharmacies that pop up in places. And there are some regional chains, a lot have been acquired, but there's a few that are still there, or they're kind of specialty focused or others. So it's interesting. We see similar where it's like the dynamic changes a lot, and it's still a group of pharmacies that very much are competing with a large chain that also owns a PBM and is going to try to benefit their chain pharmacy, right?
Yeah. The vertical integration does not help. That's a whole nother topic with the FTC and the work they're doing. But, like you said, it's a changing market. I think it just makes sense that some of the chains will probably have to right size,
Yeah. And you see that in the chains, right? I mean, they've announced over the last couple of years that they're actually decreasing the number of locations.
If we can get some of these reforms across the finish line, if we can keep up our fight and, again, get some wins behind us, some additional wins, I think the future is bright. But, it's not going to sugarcoat it. Right now is a hard time for our members. At the beginning of any plan year is hard, especially from a Medicare Part D perspective, and some of the underwater payments we're seeing right now. It's a hard time. And, we're doing our best as an association to keep our pulse on what's happening out there and report back to Congress and report back to the agencies. We don't quite yet have the full picture yet because, we're only not quite 6 weeks into the new year, but we're working diligently to understand what's really changed this year with some of the DIR rule changes and, be able to conquer that when we have a more complete picture. But I think, as we talked about earlier, those number of underwater scripts, they're growing, and that's not good. That's not good for anyone, our members or their patients. So again, hope to use all of this information to inform, Congress over the upcoming weeks. I just can't state how vital it is that we get these reforms over the finish line in the upcoming weeks.
Awesome. What should I have asked you that I haven't?
I know we talked about patient steering a bit, and that gets into the dominant, the dominant vertically integrated entities and the power they have. Some of that power comes from preferred networks in Part D, not all of it. Some of it comes from what they're able to do in the commercial market and the steering of patients. I think if anything, one thing we're trying to do to combat some of this steering is change the pharmacy access standards. The pharmacy access standards for Medicare Part D have been the same since the inception of the program. So we think things have changed. We think that it's time for CMS to take another look at their access standards.
So what are the access standards? Like, how are they defined?
They're based on urban, suburban, and rural mileage, distance. A certain number of patients have to live within a certain, mileage, in urban areas. And then it's different stratification for urban, suburban, and rural. But we have been working diligently over the last about 2 years with University of Southern California, the School of Pharmacy there and the Schaefer Center there. We've been working really hard with some amazing researchers there to develop a pharmacy shortage areas mapping tool and to show what parts of the country have become deserts over the last several years. So we have a very complete picture for 2018 and 2020, and we're working right now to get updates in place that would include 2023 data. So I think it tells a very interesting story, and we're working really hard to show that pharmacy access standards as they exist today, do not adequately cover patients that need care from their pharmacy in the country. So, we're in active dialogue with CMS to speak with them about the possibility of changing those access standards. I think that's one way that you give our members more leverage, right? Our members are located in those areas that are hard to access for other pharmacy types. So we got to keep these pharmacies open and we need to ensure that access standards are up to date. So I'd say that's one area we're working diligently on as well.
It's super interesting because in the very limited, by comparison to you, conversations I've had with some folks at CMS, there often seems to be a mindset that access means price. And access means price to the end consumer without a lot of consideration for the other elements of care that might go into it, or what price looks like across an entire spectrum for a pharmacy, or how that medication is delivered, or, a number of the other things that impact overall care and that impact kind of the ability to choose where you want to get your care. So curious if you hear some of the same sentiment and how you think about or respond to that.
Yeah, I mean, access to us means distance, right?
Right, right.
If you have to drive an additional 10 miles to get a discount on your prescription, and you don't have a car,
right,
it's not going to happen. So our work with, it's sad that the current access standards don't take some of these things into consideration. And that's what we're trying to, change the dialogue here. But, one thing that we do look at in our research with USC is vehicle ownership. And that's something that hasn't been looked at before. We know that's a concern. We know that not everyone has access to a vehicle, and public transportation is a real thing. And patients have to rely on that to get to their pharmacy. So we want things such as vehicle ownership to be taken into account when you're looking at access standards. And we want to make sure that the access standards really speak to patient populations that have shifted over the last several years. I mean, Medicare Part D has been in existence for how many years? A lot.
More than a lot of folks in pharmacy have been working. So,
right. Exactly. So I think it's time to take a fresh look at that. And CMS is amenable to that. We're having some positive discussions with them. But, that's just one way to help. But I think it's definitely an important, point that we need to look at. And it's definitely part of changing the payment model, and part of NCPA's strategic plan is to look at access standards more closely.
Yeah. Yeah. What other kind of policy topics are you get hearing more discussions around? So long-term care to the home is one that comes to mind, or kind of messaging around the definition of long-term care. Anything like that you hear and kind of see positive progression against?
Yeah, absolutely. I think when it comes to long-term care at home pharmacy services, we've made great strides. That's been NCPA's long-term care division #1 advocacy priority since 2019. Yep. So in 2019, we started educating CMS on the fact that, I guess I'll back up. Several years before 2019, we had to educate CMS on what long-term care pharmacy is.
At all. Right. Yeah, exactly.
Years ago when they wanted to do these short cycle dispensing, requirements and whatnot, I don't think anyone at the agency was quite in tune with what long-term care pharmacy, all the services provided. So, it's been a long time, and a big goal of our division to educate, decision makers and policymakers. But, once CMS kind of understood better the role of LTC pharmacy, and we got through some of those changes with short cycle dispensing, et cetera, we went to them and we said, there's a big move in the industry. Patients prefer to age at home. They still need this higher level of service, and we need you to recognize it. So, that was 2019. We all know what happened over the upcoming couple of years. In 2021, CMS did put out a memo that at least recognized that the possibility for this need exists.
Yep. It's a step.
Which is nice. It's a step, right? Getting an agency to put anything in writing is not easy. So that's a very big step. Since that time, we've been working even harder to say, okay, now instead of just a memo, document, we need a formal regulation. So about 2 years ago, we partnered with the American Society of Consultant Pharmacists and the Senior Care Pharmacy Coalition to form the Alliance for LTC Pharmacy at Home. So pharmacyathome.org, we have our own website. We have our own list of resources, who we are, what we do, what we advocate for, how this is going to help patients, how this is going to save dollars, and been able to make a lot of strides since then with a more formal, industry-wide effort. So we provided some legal backing to CMS, and kind of given them our reasons why we think that CMS has all the authority it needs to really put a more formalized structure for LTC at home in place. So we won't stop working on that. We won't stop advocating for that till it's done. I think it's just the writing's on the wall that patients, as our population ages, many will choose to age in home and age in place.
Many will have to, given the number
Absolutely.
of beds we have in long-term care facilities.
Absolutely.
And the fact that they're not growing right now. Yeah. Yeah. What message would you leave our listeners with, right? If they walk away with sort of one thing, what should they keep in mind? Or what should they do differently?
Well, I will say I'm going to try to pick a random day in March. The only March event I know is March 17th at St. Patrick's Day, right? So we need some luck, right? We need some luck. We need a little luck right now. And hopefully come March 17th, we'll have reached the pot of gold, because if we can get Congress to make these changes that we've been talking about for years and that Congress has been working on for years, if we can get some Medicare Part D, reasonable and relevant contract term reform across the finish line, if we can get the ban on Medicaid managed care, spread pricing and pass-through payments to pharmacies, fair and equitable payments to pharmacies, if we can get just those two things accomplished, that will be a very big step in changing the pharmacy payment model and giving our members, a chance at a better future and, fair payment model. So
call your representatives.
I would just say, let's all hope that by March 17th, we have some great news and that pot of gold is there.
Yep.
I'm confident that we have a very strong shot here. And at least one of our reforms, the ban on spread pricing, saves the government. Okay, so
that's always a plus. You can save them money.
Over $1 billion. Right? Everyone kind of wants to fight for that. Let me put that in this bill here so I can offset some other stuff, right? So that's a positive. And then our Medicare Part D piece is neutral.
Okay, so, perfect.
Good.
Yeah.
Perfect, right?
Yeah.
I mean,
how hard is that? Just add it on.
Yeah.
Right.
I would just say that I guess I can't impart upon people enough how important a time this is right now in Washington, D.C. for pharmacy and for reform. So again, be diligent, keep listening, keep reading, keep paying attention to everything out there. But when NCPA puts out an all-member alert and a legislative, action to take that step, please, because we'll likely be doing that in the near future here.
Awesome. So keep your eyes open for things from NCPA to take action.
Yep.
Know your representatives. Talk to your representatives. It never hurts, right? If they can put a face to the name of the issue, right? It makes a big difference.
If it's just a simple email introduction or a call to their office, just get to know them, make that introduction, get them in your pharmacy. Pharmacy visits have done a lot of positive for our industry. Getting those folks in your stores is vital, but in your environment is vital. But other than that, make sure you just have a connection with them and know them. So when you really need something, tell them, say, vote for this, do this, get this across the finish line. It's for me and it's for the patients in this community to give them a continued source of healthcare.
Wonderful. Well, thank you so much. This has been a lot of fun. Yeah. I've learned a lot, which is always great.
Thank you. Thanks for the opportunity.
And for our listeners, where do they go to say if they're not members of NCPA today and they want to be? Where should they go?
Sure. Go to ncpa.org. Take a look around our website. We definitely have a long-term care tab there. You can learn more about all the things we offer in the long-term care space as well as the community space. But, get to know the website and make sure you're reading and signed up for our communications.
Wonderful. Thank you so much.
Yes. Thank you guys for the opportunity.
Awesome. Thanks for being with us today, everybody. This is our pharmacy podcast for long-term care. You can find us on YouTube, Spotify, or Apple Podcasts. Please subscribe and continue to listen for great conversations around long-term care and how to elevate your pharmacy.